I welcome on stage Dr. Ralf Borchers.
I know it's a lot for a day, but I will try to confuse you just a little bit more about laser dentistry. Already, we have different kinds of lasers. So solid-state lasers, erbium-YAG, Nd:YAG, erbium chromium YSDG, gas lasers as the CO2, and dyed lasers. So we only use lasers of these three groups. And the main lasers we use, the erbium-YAG and the Nd:YAG from the solid-state lasers, and the dyed laser, so gallium arsenide aluminum laser. Do not work from this distance. Thank you. This is just to show you the different wavelength of the lasers we are using. So we are using erbium-YAGs, erbium chromium YSDG lasers from 2780 nanometers to 2940 nanometers. They are in the middle infrared, and we are using dyed lasers, different dyed lasers, which are suited here in the near infrared. When we use lasers, we have different laser tissue interactions. So when we are using dyed lasers, we only can create thermal effects. And when we use erbium or erbium chromium YSDG lasers, we can even go higher and create ablation effects. But what are the differences? The difference is if you use a dyed laser, you will get a reversible and irreversible zone of coagulation. And if there is too much power, or if you remain too long on the same spot, you will get carbonization. That will not occur with an erbium-YAG, because with an erbium-YAG you get photoablation without creating carbonization. And if you have very proper parameters, you can make a puzzle out of paper without burning the paper. One forward, please. Yeah, thank you. You have seen this before. It's the absorption spectrum, where you can see what laser you use best for treating tissues. So as you have seen, melanin and hemoglobin, this is the main absorption for the dyed lasers. The erbium laser has nothing to do with it, with melanin and hemoglobin. But the absorption in water is very high with the erbium laser. So that means every tissue that contains water can be treated with an erbium laser. So with an erbium laser you can treat as well hard tissues and soft tissues, because both of them contain water. With the dyed lasers you only can treat soft tissues, because only there you have melanin and hemoglobin. The dyes you are using are mainly three different wavelengths. It's the 810, 940 and 980 wavelengths. There exists a 1064 wavelength, but it's the same as for the Nd:YAG laser. So they have different absorptions in melanin, hemoglobin and water, the three different wavelengths, but you can use all of them for soft tissue procedures. Okay, and just to remain, very important, with the erbium-YAG lasers you can do hard and soft tissue treatment. With dyed lasers you can only do soft tissue treatment. Perfect. So we will talk now about erbium and erbium chromium YSDG lasers, the indications and clinical cases, and we will also talk about dyed lasers and clinical indications and treatments. This is an evidence-based treatment protocol. You can see with dyed lasers you can do very well endodontic treatments, periodontic treatments, surgical treatments and low-level laser therapy, but no restorative dentistry, because it's no hard tissue laser. With erbium chromium YSDG lasers and erbium-YAG lasers, you can very well do restorative dentistry, surgery, perio, but I recommend only open curettage, but you can't do a sufficient endodontic treatment if you are not using PIPs, which is a very new procedure. You have heard it from Dr. Pradhan. The erbium YAG and erbium chromium YSDG lasers are erbium chromium yttrium aluminium garnet lasers, solid state lasers. You have to know middle infrared range, and you can only use it in pulsed mode. It's not possible to use them in continuous wave mode because they will self-terminate if you try to use them in continuous wave mode. The maximum of absorption is in water and hydroxyapatite, and they have only a minimal penetration in the tissue, and for soft tissue treatment they have not as good coagulation as the dyed lasers. You will see it later on. The working principle of the erbium lasers is the thermomechanical ablation. So that means it's very evident and needful that you have water, because water is the mediator for the working principle. That means if you're using the erbium laser heats the water so that it explodes, and it does not only heat the water you are giving with the air water spray, but it also heats the water in the tissue. So the tissue will explode from the inside and the water spray will explode from the outside. And so you can ablate the tissue. The indications of erbium chromium YSDG lasers is for hard and soft tissue. You can use it in restorative dentistry, you can use it in surgery, implantology, prosthetics, orthodontics, cosmetic dentistry, and partially in periodontology and endodontics. Dyed lasers are semiconductor lasers. The excitation is with electrical current. It's a much more simple construction, and therefore they are much cheaper. Mode of operation is not only in pulse mode, so as with the erbiums, but you can use chop mode, pulse mode, or continuous wave mode. They are absorbing in all pigmented tissues, as we have seen in the absorption spectrum. So that means melanin, hemoglobin, but they also absorb in ointments. So if you are doing endodontics and you are using colored ointments, the dyed laser light will absorb in the ointment. So if you are using it in endodontics, please only use, let's say, calcium hydroxide and no colored ointments, because if you use it, next time you use the laser, the colored ointment will burn. It will carbonize, and your canal is filled with carbonized parts of the ointment. So if you use dyed laser, never use a colored ointment. The dyed lasers have a much better coagulation in soft tissues than the erbium YAG lasers because they are absorbing in melanin and hemoglobin. The erbium laser does not absorb in hemoglobin and melanin. As said, they are simple, small and easy to produce and not suitable for hard tissues. These are the different types of operation modes. This is continuous wave mode, so you switch it on and you have all the time the same energy. With the chop mode, you are splitting the total energy in different parts, and with the pulse mode, you get much higher peak powers as in continuous wave or chop mode, and there's a lot of time between for the tissue to recreate from the thermal heat you give to the tissue. Indications for the dyed lasers are soft tissue surgery, periodontology, orthodontology, implantology, prosthetics, endodontics, low-level laser therapy, and cosmetic dentistry. Treatment by dyed lasers is a little bit different from treatment with erbium chromium YSDG lasers, because if you treat with dyed lasers, it's recommended to use anesthesia because it will hurt because of the thermal energy you give to the tissue. Exception is the low-level laser therapy. You always get a very good coagulation, so no bleeding, but you give thermal energy to the tissue. And if it's too much, you will damage the tissue and you will get carbonization. If you're using dyed lasers in surgery, always keep them in contact mode. Exception is low-level laser therapy. There is a delayed wound healing. It more or less depends on the wavelengths, but much more important to the mode of operation you use the laser. I will show it to you a little bit later. Restorative dentistry. We will begin with restorative dentistry. So we are talking about the erbium YAG laser now, because restorative dentistry with dyed lasers is not possible. You can do cavity preparation or removal of caries, reduction of germs in the cavity, reaches up to 0.3 to 0.5 millimeters in the cavity. You can use the erbium yak in restorative dentistry only in non-contact mode, and always with the shortest pulse possible, because only a very short and high pulse can create a sufficient ablation of the tissue. So if you have not a very high pulse and a long pulse, you are not able to create a sufficient ablation of the tissue. You can generate a retentive pattern for sealings, perhaps. Exception from the non-contact mode and from the other parameters is if you do a direct pulp capping, because when you do a direct pulp capping, you are treating soft tissue, the pulp. So you have to switch to a long pulse, because if you want to reach some coagulation in the pulp, you need to apply some thermal energy, and you only will get thermal energy if you prolong the pulse. With a short pulse, you will not get enough thermal energy to the pulp, and it will not stop bleeding. So with a direct capping, you use a long pulse, defocus mode, so you can create a coagulation necrosis. You can remove composite and compomer fillings with a higher amount of water with the erbium yak, but you cannot remove metal restorations. The advantages in restorative dentistry are, of course, you have no or nearly no pain. Let's say 98% you can perform the complete restorative dentistry without any anesthesia, and no one will complain. You do not have to change the instruments. So as if you do it with a burr, you have to change burrs, but not with an erbium laser. You just change the parameters. You have no vibrations, no pressure of the burr, and no heat. It's micro invasive, and you can remove caries in a selective way, just in changing the amount of water you are giving to the laser spray. I will explain it later. You can improve the retention for adhesive fillings, and you have a clean and nearly sterile cavity because you have no smear layer in the cavity. It's a faster and better regeneration of dentin. So if you once touched the pulp directly, or you do an indirect pulp capping, there is an increase of enzyme activity, and it will heal much faster and better than with a standard treatment. Okay, here are some examples for treatments with erbium chromium YSDG lasers. You can see here multiple carious lesions treated with an erbium laser in non-contact mode with a special tip with 6.5 watts, 75% of water, 90% of air. And this is a short pulse, 140 microsecond pulse. Now you are removing caries and dentin, and you can see you use less power, the short pulse, and you use less water and less air. But why? I will show you later why you do that. This is after the filling therapy, and if you try to treat this tooth with a burr, it will break directly. So you can only do that by laser, because it's non-contact, there is no vibration, no pressure. Second case, if you do laser treatment, you can see it's looking as if it was etched. So this is directly after applying the laser. Another one, carious lesion, and this is a special tip. This is a turbo handpiece and a special tip, very short, and you have to change the distance to the target. So with a normal tip, with an erbium, you may have 1 to 2 millimeters distance to the target, so you are in the focus point. If you are using a turbo handpiece, you have to change it to 5 to 6 millimeters. Here you can see it directly after preparation, before smoothing. This is after filling therapy. You should remove the parts that are lying on the surface, because otherwise you will get a white zone after the filling. So just take an instrument and scratch just a little bit to remove the white parts. And this is the reason why you have different parameters for dentin and for animal, because you can see the water content, which is very, very important for the erbium laser, is much higher in dentin. It's 25% and 12% in animal. So in animal, you use more power and more water because you have less water in the tissue. In dentin, you have more water, so you use less water with the spray. And the dentin is softer than animal, so you use less power. And you can do selective treatment of caries because caries has 27 to 55% of water, so much more water than sound dentin. So you can decrease the amount of water when treating dentin, because you are using the higher volume, water volume percentage in caries dentin to remove it. But you should only do that if you are a little bit more experienced. These are SEM pictures after erbium treatment, and you can see there is no damage of the structures and the canals are free of any smear layer. Fissure sealing, you can do fissure sealings very, very nicely without etching. This is the only procedure you can do with an erbium without etching, because if you are doing fillings, I would recommend an additional etching because it leads to a much better retention of the filling if you do additional etching. But for sealings, it's very well if you do it without any etching. That's okay. If you have low fissures, you can use 2 watts and 20 hertz. And if you have to go deeper into the pockets, you can into the fissures, you can use more watts, so 2.5 watts. And if they are very narrow and very deep, you can change the frequency. So you can change the frequency from 30 hertz to 20 or 15 hertz, because then your single pulse has much more power and it will reach deeper than a pulse you have when you use 30 hertz. Because if you have the complete energy and you split it in parts, in 20 parts, or if you split it in 30 parts, it's the same amount of energy, but with the 30 parts, it's much less in the single part. So if you use 30 hertz and you have to go deeper, use 20 hertz and it will reach deeper because of the higher amount in one single pulse. This is a direct capping of the pulp, so if you do a cavity preparation, and you will open the pulp, you will see it later. This is the preparation of the animal. This is after preparation of the animal, and you can see it, it's looking like etched. Here the pulp is open, and now you can do coagulation necrosis of the pulp. You use the erbium YAG laser, but as I said, use it with a longer pulse because you want to apply some heat. So you use 700 micrometers instead of 140, and you use no water because all the energy is going then to the water content of the pulp, and use it defocused, and you get a very, very nice coagulation of the pulp. Then of course you cover it with calcium hydroxide. In surgery, you can nearly do everything. Removal of fibroma, hypoplasia, vestibulogingival or osteoplastics, phenectomies. And with the erbium, you can also do sinus lifts, removal of bone blocks for augmentation. Incision of abscesses you can do with diodes and erbium chromium, but I would recommend diode lasers. I will explain it later and I will show it to you later. You can do episectomy, extraction of teeth and root fragments with the erbium laser. Removal of granulated tissue with both lasers, operculectomy and exposure of retained teeth with both lasers, but only if you have to treat soft tissue. If you have to treat soft tissue and hard tissue while exposing, you have to use the erbium laser, of course. And you can do excisions and biopsies. The advantages in surgery are there is less anesthesia needed. if you use the erbium laser for small procedures, you even need no anesthesia to do that. But with dyed lasers, I would always recommend anesthesia. You have no or only minimal bleeding, so minimal bleeding with erbium YEX and no bleeding with dyed lasers, and often there are no sutures necessary. There is a minimal tendency of scar forming. You have a bactericidal effect, and very often no swelling and no pain after surgery. That's why we use lasers in surgery. You have a minimal prolonged healing time, but the quality of the tissue is much better. And if you use both lasers in surgery, you always use contact mode. The surgery parameters for erbium YAG lasers are different because you can use it for soft tissue and hard tissue surgery. If you use it in soft tissue surgery, you use it in contact mode with a long pulse because you want to create a little bit of coagulation. Water and air, very low, so 0 to 7% water. If you use it for hard tissues, that's the same as in restorative dentistry. Use it in non-contact mode with a short pulse and a higher amount of water and air. This is operculectomy, gingival cap, third molar before treatment. You can see here the treatment with only 1.75 watt and a long pulse. And you can see there is a little bleeding if you use erbium chromium YSTG because it's not absorbed in melanin and hemoglobin. So you can expect a little bleeding. This is 10 days after treatment with a very good healing. Second case, and you can see it here, again with a long pulse, and even here, a little bit of bleeding, but a very good healing 7 days after treatment. And next case, a little bit of bleeding, but a good healing. If you do the same with a dyed laser, this with a 940 nanometers, 5 watts, you can see there's absolutely no bleeding, but after 7 days, it's not looking as good as with the erbium, because if you treat by dyed lasers in surgery, it will last a little bit longer for healing than with the erbium laser, because you give more thermal energy to the tissue and it needs much longer to recreate. Second case, done with a 940 dyed, directly after treatment, 7 days after treatment. Now this is done with a 980 in continuous wave mode after treatment and 7 days after treatment. It's not looking as nice as with the others, and that mainly depends on the continuous wave treatment. Removal of fibroma, first done with an erbium chromium YSTG, long pulse, as I said. This is directly afterwards, and you see there's only little bleeding. 10 days after surgery. This is a fibroma, a very big one at the inner lip, and it's treated with a very powerful dyed laser with 50 watts, with a very, very short pulse. You can see it here, it's a little brownish afterwards, but it reaches very deep. This is 2 days after treatment with a fibrin layer on it, 5 days after treatment, and 12 days after treatment. This is a row of fibromas treated with a 940 with 5 watts, so only a tenth the power. And it's always very important that if you are treating fibromas or anything else, if you want to cut with a dyed laser, you have to use enough tension on the tissue. The more tension you have, the better it will cut. This is directly after treatment. We removed a lot of fibromas at the lip, 2 days after, 5 days after treatment. Fibroma on the other side of the lip, done with a 940, 5 watts, and it can look this way if you are a little bit more experienced. So you have no brownish areas. It's just looking like cut it with a scalpel, but without any bleeding. And there's a faster healing time if there's no carbonization. This is done again with the powerful 810 with 50 watts, directly afterwards, 4 days after treatment. This is just to compare the mode of operation. This will be treated in continuous wave mode and these two in pulse mode. So if you have only a continuous wave mode, it will work, but you have to be very careful. So if you are treating too long with your laser, you will get a lot of carbonization, and a lot of carbonization is very bad. So you have to move quicker. If you can use pulse mode, try to use it. If you have enough power on the laser, that's for sure. Then you will get these pictures. Because when you look at it 2 days after treatment, if you do it in pulse mode, there is no swelling, no pain, and the healing is faster. So this was done in continuous wave mode. You can see a little bit swelling and the patient has pain. So as conclusion, out of different and a lot of investigations and examinations is that if pulse mode is used instead of continuous wave mode, you will get a better result for you and for the patient. Episectomy. Episectomy can only be done by erbium chromium YSDG laser because you have to treat soft and hard tissue. As you can see here, a very nice epicholectitis and a fistula. So before you start, you do a normal root canal treatment, mechanical treatment and filling. And then you can start with the erbium laser, and you can do all the parts only with erbium chromium YSDG laser, just in changing parameters. So you start with a gingival cut. Because it's soft tissue, you use a long pulse. Then you start to remove the bone. Bone is hard tissue, so you use a short pulse. After that, you start to remove the granulated tissue. You remove the apex. And if you have a bleeding, you can try to coagulate it nearly without water and air. So you will get a sufficient coagulation so you can inspect the area. This was 10 days after treatment, and this is 3 months after treatment. And you can see there is not too much gone of the root, but the result is okay. Second case, this is after classical treatment. There is still an osteitis there, so we start to treat it with laser, erbium, long pulse for gingiva, short pulse for bone and for apex. And you see it's absolutely free of smear layer and of fragments, and absolutely free of granulated tissue. So you get a very, very good result and a very good long time result. Same case again, it's always the same procedure. Here you can see the root very clearly. Same procedure again, and always short pulse for the hard tissues, long pulse for soft tissues. This is the result 3 months after treatment. With a diode laser, you only can do assisted episectomy. So normally if you have an erbium chromium YSDG laser or an erbium laser, you do not need to use the diode laser. But if you do it in a classical way, so with burr, you can remove the cyst and the granulated tissue by diode laser. So here a 980 diode laser is used with 2.5 watts, continuous wave mode, 400 micrometer fiber, just to clean the bone cavity. This is the clean resection site. This is 19 days after treatment. Second case, we begin with an erbium laser. You can see very large cyst, and after removal of it, it's bleeding a lot. So we do a little bit coagulation with the diode laser. Extraction, and this is a very nice example because I don't know if you can remember the direct implant case of Dr. Suchetan. He said if there is an infection, you can put implants instead of the infection, and you can do an implantation if you can remove the root very proper and very softly. And the way to remove the root is to use an erbium laser, because if you have this situation, there's a root inside. If you want to remove it mechanically, you will apply a lot of damage to the soft tissue and to the hard tissue. But you can do it with erbium laser. First of all, you are removing the gingiva, which is covering the rest of the root. And then you take a very, very long tip and you are removing the bone, which is just surrounding the root. So you're removing the bone layer for layer, and you are going deeper and deeper and deeper. There will be no damage of the adjacent tissues, and okay, I will show it to you later. In this case, you can do it also. If you have a fracture line and you cannot reach this part of the root, then you use laser, the circular movements, remove the bone, and you can put the bone out without any damage of the structures. So you can directly put an implant in it. In implantology, you can use for preparation and implant cavity, Dr. Suchetan said it already, the erbium-YAG and erbium chromium YSDG laser. For exposure of implants and peri-implantitis therapy, you can use dyed lasers and erbium chromium YSDG lasers. You can remove granulated tissue from implants and bone, but bone, you have to be very, very careful with dyed lasers because you can cause a necrosis of the bone if you are going with your dyed laser directly on the bone. You can reduce the germs and you can use it for the epithelialization of outer and inner flap, so as in periodontology. There is a delayed growth of epithelium into the depth if you do the epithelialization. So exposure of implants, first done with an erbium chromium YSDG laser. This is before treatment. This is the treatment, and because you are treating soft tissues, you are using a long pulse. You just remove the gingiva upon the screw. This is with impression abutment, with healing abutment, and 1 week after surgery, it looks already very nice. This is 1 week later. Next case, you start removing the tissue from the cap. This is during exposure, directly after exposure with impression abutment, with healing abutment, and 1 week after exposure. If you do implantology with dyed lasers, you only can do exposure of implants, peri-implantitis therapy, and you can do it only, you can use it in flapless treatment, so as in periodontology. You can decontaminate tissues in case of open peri-implantitis therapy. And this is an exposure of implants with 940 dyed laser. This is directly after treatment with impression abutments, with healing abutments, and 1 week after exposure. Next case, done with the dyed laser 810 with 15 watts. After treatment with healing abutment, 1 week after exposure. And once again, done with dyed laser, this time 940 again, 4 watts. It's during treatment, directly after treatment with healing abutment, and 1 week after exposure. And another case, done with an 810 and 15 watts, same result. And now peri-implantitis therapy. If you have this case, it's looking very bad. And you can only treat this case with an erbium laser, because only with erbium laser you can reach a sufficient result in cleaning the implant and cleaning the implant threads. So if you look at this, there's a lot of plaque on the threads. You can clean it with the erbium laser with a short pulse and 55% of water, 65% of air. And this is the situation directly after cleaning. So it's looking like brand new. It's absolutely cleaned without any damage of the implant surface. Then you can cover it with any material. I use Easy Graft this way. And then it will heal much, much better than with the classical way. In prosthetics, you can use only the erbium lasers for veneer and partial crown preparation, or clinical crown lengthenings for soft and hard tissue, or pre-prosthetic gingival and osteoplastics. I wouldn't recommend a full crown preparation by laser because it will last much too long. This is a partial crown. There was an insufficient old filling. We removed it by erbium laser, and then was the preparation with a little step here. And this is the partial crown in situ afterwards. You can use it for crown lengthening. This is before treatment with optical short teeth. This is while during treatment, this removal of gingiva with a long pulse because you're treating soft tissues, and after that the removal of bone with a short pulse, and you have to mark the depth you want to reach. That's very, very important. This is the situation 12 months after the crown lengthening with veneers. In orthodontics, you can use the lasers for exposure of retained teeth, creation of retentive pattern for fixing the brackets, and frenectomy for removal of diastema. So in this case, it's an exposure of the first incisor, upper jaw, left side, with an erbium laser. You can see it here, contact mode. This is the exposed tooth, and you can see there is absolutely no damage on the animal because I've used the fiber parallel to the animal. So you should try not to point directly to the animal, because otherwise it may be that you damage the animal. You will see it afterwards. You will see a lot of white spots if you damage it. Next case, after exposure, you can see there's still a thin bone layer on the tooth, and it's very difficult to remove this thin bone layer without giving some damage to the animal. So this is directly after exposure of the tooth, and then the patient missed the appointment with the orthodontist. So this is 1 week later, and you can see there is a heavy regrowth of the gingiva. Frenectomy can be done by both lasers. This is done with an erbium laser, and as we can expect, because there is not such a good coagulation as with the dyed laser, there is a little bleeding. 2 days after surgery, 1 week after surgery, 8 weeks after treatment, and you can see the diastema decrease. Lingual frenectomy, which you have to do very carefully because of the glandula lingualis. You can see it here, done with an erbium laser, nearly no bleeding, and 21 days after surgery. Very, very nice healing. Next frenectomy, this time done with a dyed laser, 810, at 15 watts. You can see a little bit brownish contour. 2 days after treatment, 1 week after treatment. This is 3 weeks after treatment, and without orthodontics, the diastema decreased to 0.6, and 8 weeks after treatment, it decreased to 0.4 millimeters, just because you put away the frenulum. Next case, done with a 940 diet with 5 watts. Directly after treatment, fibrin layer 1 day later, 10 days after treatment, and 3 weeks after treatment. Frenectomy at a special patient, because this patient has an anticoagulantum therapy with an ENR of 2.5. So with normal treatment, let's say scalpel, you cannot treat her without any pre-medication. But in this case, with a laser, you can treat it. There is absolutely no bleeding, no carbonization. This is directly after or during treatment. 2 days after treatment, 12 days after treatment, without any substitution. Hyperplasia, this hyperplasia is caused by drugs. So it will come periodically from time to time. And if you want to treat this hyperplasia and you want to have a long recurrence-free period, try to give a lot of thermal damage to the tissue. So the recreation time of the tissue will be much longer, and the recurrence of the hyperplasia will also be much longer. So this time I treated it in continuous wave mode. You can see it afterwards. You have a little bit of carbonization, but in this case it's not bad because you want a long healing time to get a longer recurrence time. This is 2 days after treatment, and this is 7 days after treatment. It's looking nice again, and now you have the chance for a longer recurrence-free period because you used such a high amount of thermal damage. Gingivoplasty, you can do it by dyed laser, as you see here with 940 dyed laser, directly after surgery. And because of the very good vascularization, there is a minimal bleeding afterwards. This is 4 days after treatment. Next case in the upper, and these severe situations, you will have a little bit of bleeding. As you can see it here, this is the carbonization and the coagulation of the little vessels. This is 4 days after treatment. Incision of abscesses, I said it before, you can do it with both lasers, but I would recommend a dyed laser because if you do it with erbium laser, you still have a little bleeding and it will heal much quicker. So if you do nothing, it will be closed within 2 days. If you use a dyed laser in continuous wave mode, this is an 810 with 4 watts. You can see this is directly after treatment. The pus is draining off, the cut is wide open, there is absolutely no bleeding, and therefore you will get no bacteremia, which is much, much better than in the erbium case. And you need no tamponade. You can see this 1 day after incision, the cut remains open, and even 3 days after incision, the cut is still open. So that's much, much better than erbium laser and much better than classical treatment because you do not put something in the wound. Endodontics with the erbium and erbium chromium Y2G. Dr. Pradhan always said it with the PIP method. I do not mention the PIP method because you have seen it in his cases. Normally, you can only use the erbium YAG laser to treat the main canals. It will not reach the lateral canals because of the low transmission in the lateral canals, because all of the laser energy is attracted by the water, which is in the main canal walls. So there is no energy left to penetrate to the lateral channels because the absorption of erbium laser is in water. You can dry the main canal with the erbium, or you can make an amputation of pulp and primary dentition. So in this case, we have a broken tooth. We do the cavity preparation with the erbium laser. We do the removal of caries and the opening of the root compartment with an erbium laser. And then you can do a treatment of the main canal. But if you only want to reduce the bacteria, you have to use it without water and air. So it will dry the canal and it will remove the smear layer and all the bacteria. If you want to take an erbium laser for shaping and widening of the canal, you have to use it with water and air. Then you will get ablation of the canal walls. But normally you only want to create a bactericidal effect. Therefore, you use it without water and without air. This is vital amputation of the pulp and primary teeth. You can do this with an erbium laser very nicely. You can see this directly after the amputation, cover with the RM, and then with the crown. Endodontic treatment by dyed laser. So if you use a dyed laser, you've heard it from Dr. Pradhan, goes up to 500 micrometers and even up to 1,000 micrometers, while rinsing is only reaching 100 micrometers of the lateral canals. You can remove the necrotic tissue, you can remove rest of the pulp, you can dry the canals, and you have a decontamination of the periapical zone because the light reaches into the periapical zone. And as I said before, never use colored or pigmented ointments for treatment. This is an endodontic treatment, an old root canal filling insufficient with an apical ascites. So before you retreat it, you have to remove the gutta perca and the old filling. You can do this by dyed laser, as you have heard before. Then you do another mechanical treatment, so you reach the bottom. After that, you can use your dyed laser for endodontic treatment. But always be sure that you have prepared the canal up to ISO 30 or 40, because the fiber has 200 micrometers. So you must move your fiber in the canal, because if it's too narrow, you cannot move your fiber, and maybe the fiber will break in the canal and then you lose. So be sure that you have ISO 30 or 40 4 times, because the first time it's attracted by the smear layer. The second time you use it, you have already removed the smear layer. It will penetrate into the lateral canals, and the third time you are sure you reached all areas in the root. So after you have treated it with dyed laser, you do 2 more sessions with a distance of 3 to 4 days, and after that you can obturate it. If you do a vital extirpation of the pulp, you can use the laser and obturate it directly afterwards, but not with an epicolostitis. This is 3 months after treatment. So procedure again, this is the fiber, it's measured, you have to put it up to here, then it stops 1 millimeter before the apex, put it in, start the laser, 2.5 watts, continuous wave mode, and draw it back 2 millimeters per second. So always circular movements and draw it back, and you can see here there's debris at the fiber when you put it out. Yes, the fiber is flexible. It's a 200 micrometer fiber, and it's flexible, but it's only flexible to a certain point. So if you have, let's say, 70 to 90% angulation, the fiber may break, yeah, if it's too narrow and too curved. So you have to be very, very carefully in that case. Yeah. And even if the canal is obturated in some parts, you mustn't use the laser fiber, because it may break, and it's very, very hard to get the broken piece out of the canal. Now you have to put it to up to 1 millimeter before the apex, because otherwise you have not sufficient energy in the apical third of the root. So you have no effort of the laser in that part. So you always have to go up to 1 millimeter before the apex. Yeah, if they are not too much curved. Yeah, I said it before. Yeah, you can use it, but if it's curved very, very hard, so 70 to 90%, the fiber will not bend through that curve. It will break, and that's not good. So in that case, yeah, you better don't use a laser. You can use it for the upper part, but okay, that's only a partial. Periodontology. If you use lasers in periodontology, the erbium laser is only suitable for open curettage, because the erbium laser is ablating hard and soft tissue. So if you use it in closed curettage, you cannot control what the laser is removing. And therefore, it's recommended that you only use erbium lasers in open curettage, so you can see what you are ablating. With dyed lasers, it's different. You can use it in open and closed curettage. The laser parameters for erbium lasers and open curettage are for deepitalization, long pulse, because it's soft tissue without water and air. The granulated tissue you can remove with a short pulse, because it doesn't matter if you harm it. You just want to get rid of it. So with a short pulse, it's getting a little bit faster. Cleaning of bone and root with a short pulse, because it's hard tissue, and with a minimum amount of energy, because you do not want to ablate the bone, you just want to clean the bone. So you just put very, very little of the surface away, just very slightly. And you can generate a retentive surface on the bone, then you get a better regrowth of the gingiva. with 1.2 watt. Diets you can use in open and closed curettage. You have a disinfection of the pocket, removal of the granulated tissue, deepolarization, just the same as with the erbium. You have a longer period of recurrence if you use scaling and root planing and lasers, and there are much better results, which can be proved by more than 400 studies. Closed treatment, this is after scaling and root planing, and there's still a redness at the margins of the pocket. This was treated only once with a dyed laser, 980 this time, and 1 watt continuous wave mode, 300 micrometer fiber. When you are treating in periodontology, you start at the bottom of your pocket and you draw your fiber back in zigzag movements, just like in a parking garage. You are driving. You can do that without any anesthesia because it will not harm. When the patient complains, you have moved the fiber too slow. Yeah? Then you have to move faster. Then there will be no complaints from the patient. This is 1 day after treatment. There's a decrease of redness, and I would do 2 further appointments with 4 days break, and then the redness will be gone. This is a very serious case, and we've tried this flapless with a professional deep cleaning, scaling root planing, and laser therapy. And this is the situation 6 weeks after the initial therapy, and we have just laced all the pockets once again. And you can see it's looking much, much better now. Closed, done closed. Cosmetic dentistry, you can use the erbium or erbium chromium YCG laser for cosmetic dentistry. You can make a surface peeling of skin and gingiva. You can remove scars, remove gingival pigmentations like plaquia, and you can use it for bleaching, but not as effective as the dyed laser in bleaching. If you use dyed lasers in bleaching, you better use a special handpiece so you can use it with a higher amount of power and you can reach more teeth at one time. Liquid dam has to be applied to protect the gingiva. This is 30% hydrogen peroxide, and of course it's colored, because with the dyed laser is attracted in colored and pigmented materials, so the bleaching gel has to be colored so that there is a very good attraction and absorption of the dyed laser light. This is color A4 before, afterwards color A2. It's done with a 940 nanometer diode with 7 watts, continuous wave mode. Here we have done an internal and external bleaching, and this is another diode, an A10, 2 watts. This is a glass fiber with a diameter of 8 millimeters. This tooth was root canal treated and much, much darker than the other one. Was treated with a special bleaching gel, and remember what I said before, the bleaching gel has to be colored because otherwise the diode will not be attracted. When you look at this, the bleaching gel is white. So normally the dyed laser light will transmit through the bleaching gel without any effect. But in this case, there are titanium dioxide particles in the bleaching gel that attract the dyed laser light. But it's not to see if you look at this now. This is directly afterwards, after bleaching and incisional filling. And it's looking much better in contrast to the other incisor. Low-level laser therapy. Don't know if you are interested in low-level laser therapy, but it works very, very nice. We are using dyed lasers for it. You can also use helium neon or Nd:YAG lasers for it. The laser light, if you use low-level laser therapy, you use only a minimum amount of power. You give laser light to the tissue, it penetrates into the tissue and it is scattered in the tissue. The photons are absorbed by the chromophores in the tissue, so as cytochrome C. The coherence length is reduced by the tissue, but the coherence itself remains the same. And if you have lasers with a long coherence length, they are better working in low-level laser therapy than short coherence length. If you are pointing to a tissue with a laser, so here, or with an LED light. With an LED light, you will see the light penetrates the tissue, and there's an absolutely clearly spot. If you penetrate a very thin layer of, let's say, meat with a laser, you will see there are a lot of dancing spots at the laced site. And these are speckles. They are called speckles. That are little spots of polarized light with only a few millimeters size, which are dancing in the tissue. And these little speckles influence the energy transfer of the cell. So this is a normal mitochondrion in a cell with its normal life. And when the low-level laser light hits the mitochondrion, you can see this, the ATP production is going up. The pyruvates in the tissue gather all the energy and give it to the mitochondria. The primary results of your low-level laser therapy are the production of free oxygen radicals, increasing of ATP production. Okay, I won't go too much into the detail, but the cell will produce an extra portion energy. There will be a much shorter recreation time. The healing process is increased, and all activities are much better than without low-level laser therapy. The advantages of the low-level laser therapy are you have a biostimulation. It leads to faster healing, better healing, less swellings, faster degradation of swellings, alleviation of pain. You are blocking the nociceptive signals, a reduction of inflammatory reaction, and an increase of immune reactions. So you can use it in treatment of wounds, and it doesn't matter if the wounds are in hard or soft tissue. You can use it in implantology, in surgery, therapy of herpes and afti, if there are damages of nerves or trigeminous neuralgia or something like that, for alleviation of pain and edema, hypersensitivity of teeth, mucositis, and special form is the PDT, the photodynamic therapy. The dyed lasers have a good effect. Better would be helium neon lasers, but they're not affordable for that. So even every laser is doing a little bit of low-level laser therapy, even a hard laser. So an erbium laser has a zone of low-level laser therapy also. When you're using low-level laser therapy, you have to think about the area you want to use, you want to reach. If you want to reach an area on the skin, you just can use it in defocus mode. If you want to use an area just under the skin, you use it just on the skin. And if you want to reach a deeper area, a joint or something like that, you have to press it into the surface so you can reach deeper areas. Yeah? With defocus mode, you will not reach deeper areas. And you have to think about the tissues you are treating, because if you are irradiating fat and mucosa, they are relatively transparent, so you can reach deeper regions. If you are irradiating bone, that's hardly transparent, so there will be no deep transmission of the radiation. And if there are muscles, there are nearly no transparent because the large amount of hemoglobin and melanin. Another important factor is how often should you use low-level laser therapy. If you have an acute phenomena, you can use it 2 days after another, then you have to make a break. If you use it in chronic processes, you use it every second day, because if you use it too often, the doses are cumulative and you will get no stimulation, but you will get an inhibition if the dose gets too high. So if you use a less frequent irradiation, it will be much better. you will get only stimulation. It's just an example. The wounds were treated by dyed laser, this time 660, continuous wave mode, 1 day after treatment. This is a herpes and an afti. You can see this 4 days after. So it will not heal much faster than in a normal way, but if you have treated it once, the pain is directly gone. So the patient will not complain any more pain after the first lasing of afti or herpes. And that's the main criteria. They are absolutely happy after one session. Of course, you can remove it by erbium chromium YCG laser, yeah, with a longer pulse, but then you get this effect, yeah, you get a damage of tissue. Afti, this time done with an A10 with a special handpiece. It's a glass handpiece with a diameter of 8 millimeters. Treated only once, and you can see 1 day after treatment it's nearly gone. And directly after treatment there was absolutely no more pain. You can treat hypersensitivity with dyed lasers before treatment. You can apply the fluoride before or after irradiation. It doesn't matter. Photodynamic therapy is a special field in dyed laser therapy. You need photosensitizers to apply it. You can use it in periodontology, endodontics, in wounds, and in caries profunda. So if you use photodynamic therapy, it has no systemic effect, it's not toxic, there is no thermal effect, there is no anesthesia required, there's no damage of cell structures, and as I said, no systemic effect. So how does it work? If you want to use it in periodontology, first of all you do a professional cleaning of the pocket. After that you apply the photosensitizer from apical to coronal, staining for 2 or 3 minutes. After that rinsing with water, and after that laser irradiation for 1 minute per square centimeter. What is happening? You are staining the bacteria. You can see it here, because the photosensitizer will gather in the bacterial membrane and it will stay there even after you rinse the pocket. After you rinse the pocket, only the bacteria will be colored. So the laser light will only attract the bacteria and no part of the tissue that is surrounding the bacteria. So you can create a very, very good bactericidal effect. You can use it for endodontic treatment also, mechanical treatment, rinsing, drying, application of photosensitizer, staining for 2 or 3 minutes, rinsing with water, and then laser irradiation. So you can do this instead of normal dyed laser treatment. It will work the same way. Thank you very much for your attention. This was a very short If there are any more questions to treatment methods or indications, you can ask me afterwards, no problem. Thank you.
Thank you, Dr. Ralf Borchers. Can we have a hand for him? He's come all the way from Germany for today's workshop. Thank you, Doctor. Chalo, let's take a break from all this gyan. We'll break for lunch right now and we'll assemble back at 1:40 p.m.
So we'll do a cavity preparation now, and so if you can see, these are the cavities we have to prepare. You can see it? Just in front?
The class 3 lesions over there.
Okay.
Aesthetically very, very
In the cavities
lesions.
there are old fillings. So first of all we have to remove the old fillings. And because the fillings have much less water than enamel, we have to use more water spray with the water lace. So can you show the parameters? Are they on the screen? No, okay. Normally we use a short pulse. So this means H mode for hard tissue. This is a pulse of 140 microseconds. We use 6 watts of power, and normally for normal cavity preparation, 30 Hertz frequency I used, 75% of water and 90% of air. But to remove the old fillings, I increase the water to 85%. So the laser is used and with a special turbo hand tip. You've seen it before in my lecture. I don't know if you can see it here. It's very short and you have to use it with a focus point of 5 to 6 millimeters to the target. And don't use it perpendicular on the surface, but then all the particles will go back and destroy the fiber. So it always has to be used angled on the surface. Okay, now we'll switch it on. You will see the water spray coming out of here. The water spray absorbs the laser light and the water is heated so fast that it explodes. And you can see and you can hear all the pulses from the exploding water. So just to demonstrate, yeah, don't know if you can hear it there, but there is a popping sound.
Yeah, we can hear it.
Okay, now we'll try to remove the old fillings. A little bit more light, please. And as I said, we do not point perpendicular on the teeth, but always angled. So when we start now, you hear the popping sound.
Can you focus a little bit better, please? We're getting a little burnout here. Yeah, that's better.
Okay. Yeah, I think so. Okay. And you can see if the distance is too much, too large, nothing happens. But when I'm coming closer, you may see the white spots on the tooth. And you may
This is
see
done without anesthesia, remember.
how the filling
There's
is
no anesthetic given for
gone away.
Your hand is covering it.
The suction hand? Is that better?
Yeah, much better, much better. So that angle was fine as well. Yeah. And you can see how quick that is. We can go up to 8 watts with this laser.
So as you can see, a little part of the filling is gone already.
Can somebody ask the patient if she's feeling any sensation, Ralph?
Beg pardon?
Can we ask the patient if she's feeling any sensation?
Good. Normally there will be no pain.
My diamond is not.
And because there's so less water in the filling, it lasts much longer to remove the filling than to prepare the cavity.
Now you can see a pitted appearance in the tooth. It's not going to be an aerator-like cut of the tooth because it's going to be a pitted appearance. So if you're doing a composite laminate, this is fine. But if you're doing a ceramic laminate, then you will have to finish this with a diamond finishing burr. But having said
So now you can see. Now you can see already the patterns from the lasing. It's whitish all over.
And if you're doing, but the advantage of using a laser is there is something called laser analgesia which happens automatically. And the patient doesn't feel the sensation even of the handpiece post having done this. So in our practice now, we use this the erbium laser to do the preparation for a laminate, even if it's ceramic, and then finish it with a finishing diamond burr. I mean, theoretically it's possible to do a crown prep, which is pitted in appearance, but it will take just too long at the present time. But in the near future, we are going to have very high-powered lasers. Sorry, Ralph.
After preparation of animal, we have to change the parameters for dentin. That means we go down from 6 watts to 3.5 watts. We decrease the water from 85% to 35%, and the air from 90% to 45%.
And the reason for that is that the absorption...
Because I told you before, dentin is much softer than animal, and dentin contains much more water than animal. So we can reduce the amount of water because there's much more water in dentin than in animal. And we reduce the power because dentin is softer and because we don't want to have a sensation for the patient. And you can hear it, it's not as loud as before.
You have to keep moving the handpiece in a very steady manner. If you do it too quickly, nothing is going to ablate because there's not enough time for the dentin to get the absorption of the beam. But you don't do it too slowly, otherwise you can char the tissues as well. So it has to be a learned, very slow and deliberate movement. So as you can see, this is not a handpiece. Even though it looks like one, it's a different concept altogether from using a drill and a burr.
Okay.
We're nearly done now.
Yep, it's hard already. Okay, with the same power settings, we will smoothen the edges a little bit.
We are not going to waste time doing a filling here, because the reason why we're here is not because we want to learn composite fillings, but we want to learn laser dentistry. So we decided that instead of that, we could more fruitfully spend our time.
I will have a look from the inside. Perfect. Do we have another mirror, perhaps?
And you can see how comfortable the patient is while all this is going on. She hasn't moved, and you can imagine she's a youngish person. She would have complained of
That's not
anything
better.
that would have caused her distress.
Yep. You can't see anything with that mirror.
Mirror, mirror on the wall, who's the fairest of them all, Ralph?
Turn your head, yeah. Perfect. And use the suction once again. You have an excavator or something like that?
And this, as you can see, is very minimally invasive. We are basically only removing the carious part of the dentine and the enamel. And we don't have to do any a kind of removal of the natural tooth structure, and we can manage it if you learn the technique of doing this properly. It takes a little getting used to it because we as dentists are used to touch and feel. They're very touchy-feely people. And when you have to use something in a non-contact mode, it takes us a little while getting, there is a learning curve to it, like there is everything in life.
Okay, we're nearly finished. Yeah. Should we do the rest?
Yeah. Okay, the question is very good.
Do we need to use a diamond burr to remove the discoloration in the tubules?
And you can see here, all the areas are reached with the laser.
You can use it with a, you can remove with a laser as well.
So we like etched
use a
now.
diamond drill, but if you if it is
Okay.
Adjacent to the prepared one, don't you feel that they are decalcified areas? How would you be salvaging those places? So because even if you're going to place a dentine bonding agent and a composite, it's going to be probably a layer of composite which is going to wear out, and that's going to be an area of a defective enamel.
It's a good question, whether it's how thin is that area going to be, but when you are doing a composite restoration, don't you make a bevel? It's something similar to a bevel. I think we couldn't appreciate the fact that it was not as shallow as it looked. There is a certain degree of thickness to it, but it's a bevel so that we can finish the margin of the restoration properly, and you won't get that little discoloration at the margin. So that's the bevel for that. Okay. Pardon? You mean the pitting part of the laser, which is on that other side?
Using the laser, the part of the laser will be scattered, no?
I don't think we appreciated that on the video, but there is an aiming beam which actually tells us where exactly we are aiming. Okay, so it's more precise than using a burr, for example, because there could be collateral damage with a burr, but here the aiming beam is quite
This
accurate.
one? Yeah. Or this one? This
The
one?
aiming beam, I'll tell him to show you the aiming beam.
This one.
Let him just aim and show us, so we'll know exactly. So that's the point where you're going to get the lasing. Okay, Ralph,
Yep.
for the next case, can you just show the participants the aiming beam?
Okay.
So when you're focusing, just show
Yeah.
them where they're aiming so that they understand, because the question was, is there going to be a collateral damage because of scattering of the laser? But that's not going to happen because you're going to focus it with the aiming beam. And that's what he's doing. I don't think we appreciated that very well on the video. But we can, once he shows it to us, we can understand that better.
Okay, without light, because I want to show the aiming beam, if it's possible. You can see here, the aiming beam.
See the aiming beam.
On the skin. You can see it? Yeah? So if we're targeting on the tooth,
Yeah, now if you
yeah,
look at that,
now you can see where you are working. Yeah?
Ralph, go to about 5 millimeters and you get a proper sort of picture of that. Yeah. And can you just laze it for a second without the
Yeah.
light, please? So we can see it. Then that becomes a clearer. Can you see it now? It's very clear.
Just to make it clear,
Do me a favor, after this is done, the demonstration, go to the stall and you can see it for yourself. You can actually get the aiming, once the lasing starts, you can actually see the aiming being very clear.
I will show you the laser action on the brown spot. It might be better. Okay? Can you see?
They're worried about the accuracy, so just show them only to the brown spots without touching the neighboring, that's what I think their question is, right?
And you can see very clearly the white spots that are occurring on the brown field. Can you see that over the camera?
Can we can you stop and then show us now so that we see how accurately we can do this without really a problem. Can you focus on that area which has been Yeah, can you put the light on, please?
Yeah, once again.
Can you put the light on, please? Now he's going down. See, now he's lasing downwards. He's not going into the brown spot.
So you see,
Now you can see how accurate.
really everything of the brown field is gone. And now we are going deeper on the surface and we are approaching the gingiva. And as you can see, I never use it perpendicular to the surface.
The reason for that is that if you use it perpendicularly, you will get the plume going back into the and clogging the tip. So you got to keep it at an angle.
When you're preparing dentin, what happens to the moisture within the dentinal tubules? Because that plays a major role in the dentin bonding. Moisture within the dentinal tubules.
We're not changing that. What we are doing is that even if you're removing the absorption in the dentine, okay, you're asking me what is the mechanism of ablation of dentine. It's very simple. It is with two factors. One is absorption by the dentine itself and melting of the dentine. But more importantly, it is the pressure on top, the water on top, which is causing ablation and therefore expansion of the hydroxyl apatite crystals. So the water on top expands, it's up, and then it
System temperature
it
too
actually
high.
the interstitial tissues, which are organic in inorganic, organic in nature, is absorbing the laser beam and they are expanding and they are actually expelling out the hydroxyl apatite crystal. So therefore, we are not interfering with the dentinal tubular fluid at all. Absolutely.
You
Absolutely.
get a nice shower additionally.
In fact, there's a rehydrating effect because there's a lot of water there.
Just wait a second.
Now see how accurately you can do this. We do laminates like this and you can see the margin that you can make with this.
Temperature was
Ralph, can you just tone down the camera a little bit downwards? I think they should appreciate the margin that we can make with this, the camera. Yeah, it's a little burnt out with the camera. Yeah, can you see the margin now? You can get a margin very accurately, and so it's very easy to,
okay.
it's a very easy way of accurately treating a lesion on the tooth. The other issue about absorption in dentine is
Okay.
caries dentine. What happens in caries dentine? There is more water content because the inorganic content comes down and the organic content goes up. And the absorption of this wavelength is basically highest in water. So it gets absorbed in water, the water expands, it actually expels out the hydroxyl apatite crystal and it's called an explosive expansion. That's the mechanism of action. Now Ralph is doing the whole prep. You're doing a laminate prep, right, Ralph?
Yeah, that's right.
Yeah.
So I don't think you can see the step I've created.
Yes, we can see the margin.
On the side, I think, with the camera, it's not clearly to see.
I think you can see it though. It's appreciably, it's very accurate the margin you can make with this.
And you can see I've never hit the gingiva, otherwise you would see white spots on it. Yeah. So you can aim very, very good with this device. Okay, nearly finished. Okay, I think it's finished now. Okay, and we have seen you can do all the procedure without any anesthesia. And if you want to speed up, you even can use more power than I've used, because I used the same as before, so 6.25 watts and 30 hertz, the short pulse of 140 microseconds, 75% of water and 90% of air. And you can go up to 8 watts if you want to, but maybe then there is a sensation for the patient if you use 8 watts. Okay. That's it.
Thank you, Ralph. That was very nice. Now we're going to do some soft tissue procedures with the diode lasers. We have two cases. One is depigmentation and a frenectomy, and the other case is depigmentation. And we would like to show you all the lasers that are available at all the stalls here. So we are going to do part segments so we have 5 lasers and we are going to do 5 parts. So both the quadrants of the depigmentation will be 2 different lasers in that one patient. The frenectomy will be the 3rd laser, and then the wavelengths that you can see for yourself how, in my personal experience, everything works. But you need to see that for yourself.
So I think we will start in the lower with the frenectomy, because one of the lasers directly ready to start. But before we do this, we will give an infiltration anesthesia, because it will hurt without anesthesia. So we'll make a little shot and perhaps a little bit of surface anesthesia.
Okay, can you ask?
After preparation, do we have to etch the enamel before using a composite?
Yeah, yeah.
Yes, you always. There's a lot of research having been. This is one of the areas where a lot of papers have been published. I would say, if you look at the review of literature on this, I would say 25% of the papers say that you don't need to etch. 75% of the papers say you definitely need to etch. And I think that it's safer for us to etch and then bond. Some of the papers also say that if you do laser etching, and that's a separate concept
3.5 is okay.
then that reduces the bond strength, but that's about 5%. Sorry? So I think the consensus here would be that you etch even after doing a laser etch like what we did right now. Any other questions while we are preparing for the next patient?
Okay.
How will you differentiate clinically that the infected dentin is completely removed and the affected dentin is retained?
You can use the Diagnodent, which is a laser. The diagnostic laser, you can use that if you want. You can also use your tactile sensation, but that's not as accurate as you would want, but the Diagnodent would be more accurate. I prefer, if it's reparative dentine, you can see the difference in the color, and you can feel and you have a feel. But if you're in the slightest of doubt, get that layer out. It's as simple as that. But the Diagnodent will give you a good reading. It's a laser. It's a laser which works on the principle of fluorescence. What happens is, does anybody understand the concept of fluorescence?
No, I do the frenectomy first.
The fluorescence is absorption of the laser wavelength, and then it emits
It's already here, so
at a
it's
different
okay.
wavelength or the same wavelength, but you get a glow. And the same thing happens with a carious dentine. It absorbs the particular wavelength of the diagonal dent, and it emits it in a different, and then it beeps if there is a carious dentine. So it's a far more, we know that there's 85% accuracy with diagonal dent, with all the papers that have been published. Any other questions? Very interesting questions are coming up. So if there are more questions, please.
Is it in removing subgingival calculus?
Again, it's a very good question. There is one erbium laser which is actually got a feedback mechanism, and they market it like that. It's the key laser, and so it's got a diagnostic laser attached to it as well. And it is reasonably effective, again, from all the studies we've seen. It's very effective in removing subgingival calculus. One of the studies that I saw recently published, it said that it's more effective than your ultrasonic scaling in detecting with this feedback mechanism. But we're still in early days. We need more research to actually come to a conclusion, but it seems like but lasers can remove subgingival calculus very easily.
I will try. Think it's too much for Indian skin?
Again, vision is better.
250?
So you can see down much better than you could with a scaler. The problem with scalers is that there is a lot of bleeding because the tissues are very inflamed and therefore they'll bleed.
Okay.
But here there is automatically a
So I have
coagulative
2.5.
kind of a...
Because you always have to keep in mind if there is a shot given to the gingiva, it's getting more pale, so the absorption is getting poorer. Yeah. So normally in Germany, I would use 3.5 watts for frenectomy, but because the skin of an Indian is much more pigmented, we would start with 2.5 watts, and with a pulse interval of 0.05 microseconds and a pulse length of 0.2 microseconds. So it made in total an average power of 2 watts.
Yeah, that's right. I wanted to know the average power. So now that we know that the average power here is 2 watts, because we are shutting off the lasing for 25 seconds of the time, 25% of the time. So if this power is 2.5 watts, it's actually working at 75% duty cycle, and therefore it's 2 watts of power. Now, if that interval was 0.20, then it would be 1.25, would be the effective power of the lasing, okay? So that's something that you will have to worry about. Now, Ralf, can you explain why are you using it in a gated mode and not in a continuous wave mode?
Yes, I love the pulse or gated mode because the tissue has more time for recreation, because there is thermal energy at that time when you laser it, and when the pulse is interrupted, the tissue has time to cool down before the next pulse is coming. So the amount of thermal damage is less than if you use continuous wave mode, because then you are giving energy to the tissue all the time and it gets warmer and there is more thermal damage. So we try to do it in gated mode. Before you start, you have to initiate the fiber, and we do this. Perhaps you can show it. No, it's not on the. Okay, we do it. Okay, so just fire.
Just 1 second, Ralf. He's test firing. Ralf, can you just wait for a second? We're getting a question here.
Yeah, okay.
Sir, one of the methods of etching the enamel for fixing the direct bonding bracket is a laser. Is it the same mechanism or something else different? Will you enrich your knowledge?
Yeah, it's the same. It's absolutely the same mechanism. You can even, after you've done a laser etch, you can either directly bond it on, or you can even etch it with a phosphoric acid etchant if you want. Okay, so there is Yeah, perfect. I mean, a lot, and you know, it's worked very well. And we have one of our fellow students who has done a huge research project on this, and he's found that it's easier to just etch with a laser and then bond it directly. Okay, Ralf, go ahead.
Okay, now we start. It's very important that you give enough pressure on the tissue, otherwise it will not cut very good. So we'll try to give a lot of tension on the tissue.
Ralf, can you tell us what laser wavelength this is?
Yes, this is a 940 nanometer wavelength.
Okay.
Do you remember the settings? 2.5 watts. So 0.05 microseconds pulse interval, 0.2 microseconds pulse length, and an average power of 2 watts.
There are other methods of gating your laser handpiece as well. And once it's by going into contact, non-contact, contact, non-contact, and keep on moving the laser. That's one of the other ways of doing
We have to use this camera.
And that you'll only, you know, once you do the programs and you get used to it and start treating patients, you'll understand what I'm saying.
Frenulum has gone.
After that, it's
That's better. Okay. Now you start lasering, and you can hear it. Okay, there must be more tension on it. And you always have to move the fiber. If you are stopping, you directly get carbonization. And you always create a rhomboid shape.
Can we go up close a little bit, please? We need them to appreciate that there is no carbonization while you're doing this, Ralf. This is beautifully done, and you see the tissues are only white and brown, and there's nothing that looks like black over there.
Yeah. And then you have just to control this. If there are still fibers left, but in this way it's okay. You can move it. Yeah. So you can leave it this way, and you always get this rhomboid shape. But you can see absolutely no carbonization on the edges. Yeah? But therefore you have to move the fiber all the time. Never stop to move the fiber.
Will that also work as a gated kind of a mode, Ralf, the movement of the fiber?
Also with gated mode. That doesn't depend on the mode of operation. You always have to move the fiber. Never stop on a point. Otherwise you will give too much thermal energy to that point. It will accumulate at that point. So always keep in motion, always. And that it's for periodontic surgery in every case. Always keep the fiber in motion. Never stop at a point.
And we've got great hemostasis. There's not even a drop, right?
Yeah. Yeah.
That's the main advantage
Okay.
here.
We finished down there.
Appendectomy is done.
So we change lasers now for the
See how quickly we can
depigmentation.
do appendectomy.
I will give a little shot for the upper.
If you have to put this patient under anesthesia for a procedure like this, that would be dental terrorism. That's what I call it. Because you have such a simple methodology of doing it. Why are you not doing that? And Ralf is being very conservative by anesthetizing. I would have done it without You really don't need, if you're going below 2 watts, normally 1.5 watts. You don't need anesthesia.
So normally if you start to do procedures, start with lower powers. It's always better if you start at lower powers, and if it won't work, you can increase the power. But don't start with high powers, otherwise you may burn the tissue directly. If you are experienced, you know what powers you have to use, and you have to think about it. So as I did before, so I said normally I would do 3.5 watts in Europeans, but only 2.5 watts here because of the much better pigmentation of the gingiva. So there's a better absorption because of the better pigmentation, and I need less power. Okay.
Do you need to lace the entire surface area of that rhomboid shape?
No, you need to go up down to the periosteum without involving the periosteum. So you can actually see the periosteum. There's one fibrous layer on top of it. That's when you stop. Because with the diode laser, you don't want to go close to the periosteum. Or don't lace the periosteum directly. Is more likely. Yeah, you want to keep. Oh, you will burn the periosteum, and that's not what you want.
What do you recommend for depigmentation?
2 to 2.5.
Okay.
And you want continuous or?
What about
No,
recurrence
we will see
case of
gated mode
depigmentation?
is okay.
No, it is in the gated mode. 25 hertz.
Recurrence of depigmentation will happen.
motor.
Will definitely happen at some
Okay.
point in time, because it's just the melanin
And average power
pigmentation which is going to be laid back on
1.2.
by the
Okay.
bulb.
We try it.
So, but
This one's, you can
how long does it
even
take
the lowest
is
watt
very
is
variable.
980. You can go even at
Oh, much more than that.
0.4, 0.6 watt, you'll get
Much more than that, in
even
years.
at 0.4, 0.6,
In years,
just try it out.
we've done some
Okay.
cases 3-4 years down the line.
We
which will
should
not
lower
recur.
it
Some
directly.
cases have recurred in 2 years' time.
Make it to 0.6 and work up from.
Yeah, the severity is much less.
Because,
But you know what? I look at it from this
this
perspective.
one we were using it.
You don't need anesthetic. You do it at 1 watt here, and you go in with a very light brush motion.
Even at the lowest power.
Even if you do it every 6 months, people can get waxing done every month, which is so much more painful.
Okay.
I don't see any reason why a
is it
patient
already
can get
initiated?
depigmentation done every 3 months.
The fiber?
Is that fiber initiated? It's not initiated.
Okay.
Don't play around with the lips right now. I think,
Business
yeah.
card, yeah.
I think black lips look nice.
Okay.
It's the black gingiva which is the problem. I mean, she has lovely lips. Look at her. Yeah, it will. Of course it will. It's very, very good for these little warts that you have. See around. We did it for a lot of my dentist friends and their wives get it done with lasers, the warts and all these removals and stuff. They're wonderful.
Leave it open so that he can reach the. Yeah.
Okay. For depigmentation, this time with a 980 nanometer wavelength, and we are starting with 1 watt power, and it's a frequency of 75 hertz and an energy of 5.4 joules. So it's an average power of 0.5 watt, which is not very much. So let's see if it works.
There are 2 ways of doing the, and you can see there's a plume happening there. Can you see it? And that's the thermal effect of that on the laser. There are 2 ways of doing this procedure. One is to directly go in at a 90-degree angle, and the other one is to use light brush strokes to do it. I prefer to use the light brush strokes, but that is a personal choice. You can do either.
So from while to while, you have to wipe the fiber, because if there is a lot of the tissue at the fiber, the temperature will concentrate at the fiber and the laser will not cut any longer. So always be sure that you work with a clean fiber. And you can see, even if there is only 0.5 watts, it works very well. And you're just slightly touching the surface and removing the upper parts of the tissue until you reach the pigmentation.
And you can actually see the melanin pigmentation slowly disappearing. As we go into the pigmented areas of the mucosa and we are ablating it, you will see that the pigmentation is already.
I think should remove the rest from the tissue so you can see it better.
The effect of the diode laser is also more effective the next 2 days, 48 hours down the line. It's not as, it looks, because the absorption of the melanin is now, and it's going to slowly ablate it, and it's more effective when you see it 48 hours down the line. So of course, even now, we can see that there's a much more lightening of that area than on the other side.
Yes, yes. Can you just increase it a little bit? Yes. Wattage.
I think effectively you need about a watt, you need about 0.8 to 1 watt, Ralph.
0.7 average.
Okay, so it's an average of 0.7 watts now.
Ralph, I think you'll need to go up to at least 1 watt.
Big one?
You don't think you'll need to go up to 1 watt, Ralph?
Yeah.
It's too low right now, the setting that you're
Check
using.
1.3 on average.
So the average power is 0.7.
Yeah, we need
Can you send
effective average.
to 1 watt average power?
You can already see it's beautiful. Well, he was using very, very low power settings, and even with that, the patient won't feel anything at all. Except from maybe a little bit of
Perfect.
heat.
So now we're using 1 watt average power.
This is in contact mode.
All surgical procedures are in contact.
The soft tissue modes will always.
Non-contact is only for low-level laser therapy, and non-contact is for endodontics and periodontics. Okay.
There, we're nearly done now.
So you see it's looking much better now.
Very nice, Ralph.
And I think we will compare it to the other side with another laser, okay?
Yes, and 48 hours down the line, you'll see a little pink area there. And if you feel need to sort of revise it a little bit, you can always.
Okay.
It's really not painful.
So we will take another laser.
Can we have a look at the laser that you just used, Ralph? So people know what laser we used just now?
Yes, this was a Sirona laser.
Okay.
980 nanometers.
Okay.
And for the rest of the procedure, we have used it with 2.0 watts.
But effective power was 1 watt, right?
So yes, the average power was 1 watt. That's right.
Okay, let's go with the next laser. So if you can just tell us a little bit about what laser you're using, and what power settings.
Yeah, okay, it's a Dr. Smile, and we will use it with 0.5 watts, and this time in continuous wave mode. Okay? Okay, so we start the procedure. We need the suction. Okay, that's okay. And you see you really need the suction because it smells and there's bloom.
And also as a cooling mechanism, isn't it?
Yep. But it's not working properly.
Well, unfortunately, this is a makeshift dental chair. But thanks to Dr. Acharya, it's come from her practice. We're really thankful that, she's got this wonderful mobile sort of track that brings it in.
Not yet. Just. Okay. Okay. Now we'll try a little bit more power in continuous wave. So let's use 0.75 watts.
It actually takes about
0.8, okay.
It's so quick.
Try this. It's okay. Could you please switch it up? Perfect. So we're a little bit faster with 0.8 watts. And remember, this is continuous wave mode. Okay, take a look at it.
Any more questions on this procedure? Anybody has any questions? I haven't got any questions from the back. I need questions from the back as well. What is the mechanism? You know, I remember I spoke about hypothermia and then coagulation. So what you're seeing is the coagulation of the proteins in the surface of the epithelium, and it's actually, because it's coagulating, it's shearing off from the mucosa underneath. So it's layer by layer. You can actually shear off layer by layer of this whole thing. And because we are not carbonizing, or we're not even vaporizing it, if you notice.
Is it okay?
We're just going in and it's getting detached from the mucosa underneath. So that's actually coagulation of the protein denaturation stage.
And you see there is an all-time good coagulation, absolutely no bleeding.
We need higher powers.
And you have to go layer for layer over the tissue. You cannot remove everything at once.
So you go like this, like this, like this.
So
and thickness-wise, you go like this.
just touch the whole area and then control it once again. And if necessary, do it again.
Any questions from the back, or anybody sleeping in the back? This is the diode laser. You use a diode 9, for hair removal as well. The skin has 3 or 4 different types of lasers that you can use. You can use the diode, you can use the erbium for skin resurfacing, you can also use the Nd:YAG. So you have 3 different uses for different purposes. The erbium is very good laser for skin resurfacing. So if you have, if you want a smooth...
Okay, that's it.
Priyanka skin or Anushka's skin, then you resurface it with an erbium laser. But you can also, if you have a more melanin pigmentation lesion, you can use a Nd:YAG.
So if you compare it, in general, there is no difference in result.
Yeah, there will be.
Yeah?
We don't expect that.
Okay. Thank you very much.
Very good, very good. We have one more patient of repigmentation and 2 different lasers. We've now done 980.
Thank you.
Okay. Now we got to go in with an 810, and we've done 940 as well, right?
Yes, it's a 940.
Physically
Can you change
remove
it,
the
or
melanin layer.
do you only have the pre-settings?
You can change it.
Ah, okay.
You can change
I don't think there are any erbiums in
from
Kerala.
1 to
All I know.
Ah, okay. So we try with 1 watt first. Okay, topical, yeah.
The very good question here. We're getting great questions here. The question is,
Application of laser in oral submucous fibrosis.
what is the application of lasers in oral submucous fibrosis? Well, there are 2 or 3 applications. The first one is reduction of pain associated with the ulcerations that are caused by submucous fibrosis. If it's an ulcerative lesion,
only this one.
and a lot of
We'll try.
SMF lesions are ulcerative, you can reduce the pain associated with it. Okay, 1. 2, you can cut the bands and increase mouth opening, but it's not a permanent solution. It is going to recur. Okay, and 3 is, of course, the patient's pain with a low-level laser therapy. The pain also comes down. So 3 applications.
From 0.1, you can go to 5 watt, any watt if you want.
Okay.
Okay. And
If the patient stops doing what he's been doing and that is causing the causative factor, then you have hopes, but not otherwise.
That's
We
fine.
have 200, but he said 400.
Yeah, that's fine. For surgery, it's
For
fine.
the SMF,
This can be hooked
use
up to
any
the unit, so it
laser.
becomes a part of
But
the
you
unit.
can use a diode as well.
Designed with the hookup.
Use the erbium.
You connect it and it stands there.
Ah, okay.
LLT, low-level laser therapy. It's wonderful.
You have the foot switch here.
Yep.
Depends on how severe the condition
Are
is.
you ready?
Yes.
But most patients
I'm
respond
ready.
within 2
I
to
don't know
2 to 4
if the audience is ready. Mode. And we'll try to do that with only topic anesthesia.
What setting have you got?
It's 1 watt continuous wave and 810 nanometers.
What continuous?
1 watt continuous wave.
He uses 810.
810.
Yeah.
And this is white star.
Yeah, this is white star from creation of
What is the application
Okay.
of laser in dry socket management?
Yes.
It's a very good question. What do you do with dry sockets? I was explaining that to a group of people at lunchtime, but it's great. It's a great use. You have to use the erbium because the dry socket, the problem is that there was no clot formation.
Can you show the laser ones? Yeah.
Okay, let's finish with this and then.
Okay, this is the creation, and you can see surgery program 1 watt and continuous wave mode, and no timer, and it's ready to use.
and you can use from 0.1 to 5 watt.
Yes. Okay, so we try to do without anesthesia. So,
Switch. Release it once it has gone on standby. Yeah. Please release and put again.
is it already initialized, the fiber?
Please release the foot switch and press again. Yeah, now press it. That's it.
Ah, okay. Now it works.
Give anesthetic for this procedure.
In Germany, everyone
Yeah.
requires anesthesia.
They are more
For
scared
this.
also, yeah. We are a fearless race. The question that we had, Ralph, I'm answering a question not in your situation, but somebody asked me a question about dry socket. Okay, the problem with dry socket is that the clot has not formed at all. So there's going to be a healing now from down upwards, rather than from the clot retracting and then being resolved into bone. So what do we have to do? What have we been traditionally doing? That's exactly what we'll have to do now. We'll have to create a clot. We were using things like Albogel and stuff like that so that it would numb the
him up
pain
a little
down.
bit.
What we got to do is then create a bleeding socket. That's what we were trying to do, right? You take curettes and try to make it bleed, and then, so that's what we do with an erbium laser. The erbium will make it bleed. So we make it bleed, and you can even stabilize the clot with the diode laser after that. So make it bleed properly, ask the patient to, with a pressure pack, and then clot it with a diode. That would be an ideal solution. And we've done that, yeah, sorry.
Okay, as you can see, the areas were much smaller, but were
No need at all.
depigmented. So we're nearly ready on the right side.
Sure.
I would like to say that when we are doing this, of course we do it on patients where there's a lot of gingival display. So when we are using this, there are
Maybe.
two factors which I found. One is
one
to be
have a look.
careful not to nick the marginal gingiva, because you can just lose it for good. Okay, so this is a very important point. Secondly, I found that the most difficult part where we encounter the maximum pigmentation is very difficult to remove is in the interdental part. The interdental papilla has got like really very deep, at a very deep level, there's a lot of melanin there. And last but not the least is not to promise the patient that it's gone for good, because it will come back. Question is, how fast does it come back?
It's okay already.
So in one patient, I did it
finished
2
by
or
the
3
right side.
times. By the time the patient was satisfied, because apart from the gingival display, the most thing that this patient was going on telling me, but doctor, between the teeth it's still visible. Because that's the part which is going to be immediately visible at the smile line. So in the interdental papilla, you have to maybe go 2 times. You have to call the patient back after like 1 week or 10 days and do it again. Yeah. So then, in about 6 months, you can expect the patient to come back. So you have to tell them this is a cosmetic procedure. To different people, the pigment comes back differently. So it's not a forever thing. So I just wanted to make a comment on that.
Okay, we finished the right side. Now I think, thank you very much.
You're welcome, Dr.
Now we can change to the next one.
Yeah, thank you, Ralf. Again, very easy, no anesthesia.
Know him from there on.
Okay.
You want to show this? You want to explain?
And now again, can we have a look at that?
5 watts, so you have a perfect.
Okay, and it's 810 nanometers. And it's now put to 1 watt continuous wave mode. Okay.
Absolutely.
Okay, that's it.
So no anesthesia, you can do this every 3 months to the patient even if you have to, which you don't have to, it's much more than that. And patients are comfortable. You may have to revise it again. You need to wait for 48 hours to actually see the proper effect of it. And if you feel that there is some areas left, patient can come back again and you can revise that. And because you don't want to overdo it the first time, you may want to underdo it and then revise it. That's a better option that you have. And of course, you don't charge the patient again. Thank you, Ralf.
Oh, you're welcome.
I think he deserves a big round of applause for it.